The American College of Cardiology is pleased to present this online education program titled Successes from the Patient Navigator Program. We are very pleased to welcome all of you. And now it is my pleasure to introduce our moderator, Dr. Ty Gluckman. Dr. Gluckman, welcome.
Thanks, Kendra, and thanks everyone for taking time out of your busy schedule to join us. I want to welcome you to the third webinar of the year. And this thematically is focused in on the original Patient Navigator program and challenges that were faced and successes that were achieved as a result of participation in the program. We're really fortunate to have two great speakers join us today, Randy Cash and Kim Marshall, and I'll let them both introduce themselves in a moment. We are hoping to make approximately 10 minutes available following each of the two respective presentations to be able to have you post questions and have our speakers answer them as best as possible. If we get into a situation where we're unable to answer all of the questions, we will make sure that they are posted on the listserv and are made available to all of you to be able to see responses from our speakers today. And without further ado, I want to be able to turn things over to our first speaker, Randy Cash. And thanks again, Randy, for your opportunity to present today.
Well, thank you for inviting me. My name is Randy Cash. I'm the Transitional Care Coordinator at Aurora BayCare Medical Center. We took part in the Patient Navigator 1.0, and we are thrilled to be taking part in Patient Navigator Focus MI. So what we're going to be talking about today with my slides are improving the follow-up rates and utilization of a Phantom appointment and a LACE tool. These are two of the items that we designated as we were lacking, and we had really great successes with it. So once again, I work at Aurora BayCare Medical Center. We're located in Green Bay, Wisconsin. We're a 167-bed facility, and we're a delegate, as I mentioned before, we're a delegate hospital for the Patient Navigator Focus 2.0 program. Our team is headed by Dr. Scott Weslow. The Director of the Quality Department is Julie Pomasol. My partner in the Patient Navigator program, who I could not do this without, Quality Improvement Coordinator Julie Manny, and then myself. So Patient Navigator 1.0, so when we started this program, Aurora BayCare Medical Center was already excelling with the Action Registry Get With The Guideline metrics, the CHF performance measures, identification of both AMI and heart failure patients, and providing specific education. Conversely, the areas that needed more attention included assessing for risk of readmissions, as well as scheduling the 7-day follow-up appointment for our CHF patients, and ensuring that they were actually attended. Prior to the implementation of the program, there was no process in place to account for patients discharged on the weekends to ensure that there was a follow-up appointment on their discharge paperwork. And there was also poor compliance with the attendance of follow-up appointments. Additionally, as I said, there was no process in place for risk of readmission. So as you can see on the slides, our follow-up visits, the baseline data for follow-up visits at the start of the Navigator was 74%. Patients discharged on weekends were not receiving their appointments prior to discharge. They would have an appointment on the on their discharge paperwork, but it would be to call and follow up, set up an appointment. Patients not understanding the importance of follow-up, and discharge not fully understanding the disease process. And then once again, there was no process in place for the risks of readmission. So at ABMC, a transition of care nursing position was created to address these issues in an effort to reduce the CHF and AMI 30-day readmissions. The transition of care nurse position was created, was used to provide a more thorough review of the education of patients and their families. They could just spend more time with the patients than the nurses on the floor could afford. The transition of care nurse then will contact the patient over the phone, CHF patients and AMI patients after their discharge at specific intervals for 30 days to ensure that they're comfortable managing their care at home, make sure they're following their medication schedule as as planned, make sure they're not experiencing any side effects from any medications, and try to catch any issues that come up before they just show up into the ED. Stressing the importance of their appointments, arranging services as needed, and of course providing further education. Using a multidisciplinary approach and partnering with the cardiology outpatient clinic, we also developed a process in which a phantom appointment is created on the weekend discharges and appears on the patient's discharge paperwork. So what the phantom appointment is any patient that is admitted on a Friday evening after I've left for the weekend, or they're here on Saturday or Sunday, they're automatically set up with an appointment with our cardiology team at 9 o'clock on Wednesday. Then when the cardiology comes in, if there's too many patients, we'll call them back and reschedule those appointments. But that way everybody has a guaranteed follow-up date and time. We also developed a LACE tool, which I'll be going over later in the slides, but basically what LACE is, it's a tool that helps identify high-risk readmission patients. They receive a score, and depending on what the score is, anything 10 or higher designates them as a high risk for readmission. And LACE stands for the length of stay, the acuity, the comorbidities, and how many ED visits they've had in the last 6 months. So here you can see, this is a slide that we have. This is what was provided to all the floor nurses. This is on every floor, and what this is for our patients, it's an algorithm that was established to account for the step-by-step procedure for nursing to follow to ensure that the patient would have a follow-up appointment prior to discharge. The phantom appointment is made for the patient on the following Wednesday, as I said before, and the nurse leaves the message with the answering service. So the cardiology office is alerted on Monday morning, and if there's any conflicts, that way cardiology can resolve that. So basically what happens is the patient comes in and they just follow this algorithm. Like I said, a lot of education was done with the nursing staff, the floor nurses, and the supervisors, and we have seen really great success with this. So they just follow this algorithm straight down, and if there's basically CHF mentioned in the patient's chart, they will get a CHF follow-up appointment. This is a modified LACE tool. Assessing for risk of readmission was another opportunity we definitely went and had an intervention on. The need for this program was, the need to have this process was automated into our EPIC system. So soon after the start of the Patient Navigator Program, LACE was embedded into our EPIC, and then the transitional care nurse will use this to help identify those patients who are high risk for readmission. So as you can see, there's a score that the patients will get for how many days they've been here, the acuity, how many comorbidities they have, and then, as I said earlier, how many ED visits they've had over the last 6 months. Anybody with a LACE score greater than 10 is automatically enrolled into our program. This is what it looks like. This is what our tool looks like in EPIC. So anything in the green, if it shows up in green, they're a lower risk. They're a moderate risk if they're yellow. And if their score higher than 10 or higher, they automatically shows up in red. And the nice thing with this is even if a patient is in yellow during rounds, we'll talk with the nurses during rounds. And if they're in yellow, sometimes the nurses will be like, they're really close to a 10. I really think they could do with some more follow-up. Can you please follow them? And then we'll be more than happy to pick those patients up. So some of the successes prior to the implementation, compliance in scheduling a follow-up appointment within 7 days for CHF and having it actually written into the discharge paperwork was only at 74%. So after starting our program, you can see there were some highs and lows, but at the end, we ended up having a very nice number of 96.7%, which extended our goal of 95%. So we were really happy with the process. And right now, it's about the same. We're in the mid-90s for our follow-up appointments. Now, the CHF patient follow-up percentage, this is how many patients are making it to the follow-up appointment. So for the metric regarding the follow-up appointment attendance, the baseline before starting everything was actually at 40%. And after implementation, compliance improved to 49 and then to 98 by March 2017. And we are continuing to see this. A lot of this is done through that Patient Navigator Program, through having their transition to care nurse, and also making sure that we have that phantom appointment. We have seen really great successes with this, and we've seen our numbers go down with readmitted from those who do follow up. So those are the two areas that we really looked upon, and we've seen great successes in all of our areas that we really look for during our Patient Navigator program. And that concludes my presentation.
Randy, thanks for a great presentation. I think there are a lot of great takeaways. I know we have several people on the phone, a number of them, and just as a reminder, in the left lower corner of the web screen that you have, you should be able to type in questions, and I will do my best to feed those to our respective speakers. But I will tee off, Randy, and while others are typing in their questions, ask the question. It's a very innovative and creative way to think about these phantom appointments because it gets something on the books and something is better than nothing. How problematic or challenging was it for the clinics to find out that they were having to move it? And I guess since it was always at 8 a.m. on a Wednesday, I'm presuming that frequently that appointment was moved. Otherwise, everybody would be showing up at 8 a.m. on a Wednesday. How did the staff adapt to that, and how long did it take for them to get used to that kind of a workflow?
Actually, it didn't take long at all for them. They were really they were on board with this. We had meetings prior to all this taking place. This was well set up, and they actually have a block of appointments that are kept open on that day. So even though there is, even though we set the appointment up at 8 a.m., we have a block of appointments from like 8 to 10, 8 to 11, that where they could just slide those patients right in there. So it was actually very, it was not challenging for them. The most challenging part was getting the education out onto the floor of the nurses and making sure that they set up that phantom appointment. Because, you know, as you know, we get used to things in a certain process. And it took a while to roll that education out and to get everybody to follow up. So that was probably the hardest part of it.
Great. And in follow-up to that, was there frustration, or I guess it's how it was messaged to the patient? Did the patients leave knowing that they had an appointment on their after visit summary, it was sort of on the books, but it was likely to change, and they would expect a phone call as opposed to rearranging plans for who would be bringing them to an appointment, etc.? I guess what kind of education was sort of transmitted to the patient in terms of the expectations, either related to date or time of that appointment?
So that's where, and then also to add on to the last question, actually the whole idea for the phantom appointment came from the cardio clinic manager. So they were really on board from the very beginning of it. But with the patients, that's where the transitional care nurse really comes in handy. They're the ones who go into the rooms and they educate everybody on the disease process, and then we go into the follow-up, the importance of follow-up, and then we describe the whole process to them.
Great. And a reminder for those of you who maybe are coming on a little late, just if you could please key in any questions you have in the left lower corner of the chat box, it would be greatly appreciated. I may ask an informal poll where people could type in their responses is, what percentage of sites that are on the call today have the ability for staff in the hospital, nurses, advanced practice providers, or physicians to schedule into a scheduling system on the weekend? Because I think it's a struggle that all of us face overall. And Randy, to that point, while people are sort of typing in their responses to that, did you have any mechanism, or do you have any did you have any, or do you have any today that allowed staff to be able to directly schedule in that separate system? Are you on the same EMR in the outpatient and the hospital setting? Some of those questions, because it may have informed why you went about the way you did.
Yeah, we do share. We all have Epic. So we're able to see each other's notes, the clinics and our hospitals. Basically what we do is there is a section in there where the nurses can put in a follow-up appointment, but right before being discharged, we have a TAPS office that we call Monday through Friday. And then what happens is we call TAPS. They look into that follow-up section that's in Epic. And for instance, a CHF patient will have a cardiology visit within 7 days post-discharge, and a PCP visit post 7 days with discharge. And if they saw any other specialty physicians, such as maybe endocrinology, then they'll have that follow-up in there as well. And TAPS will make all those appointments prior to discharge. And one thing that we've added, just to ensure that these are on there for the weekends for those patients who come in Monday through Friday, every Friday evening or Friday afternoon, I meet with the hospitalists and I meet with all the doctors, the attending physicians of our CHF patients, and then I go in and make sure that if they're going to be discharged over the weekend or they have a possibility of being discharged over the weekend, I put that appointment into the system and then call TAPS office and they make that appointment. So that way, if they're discharged on Saturday or Sunday, it'll actually show up, follow up with Dr. Westlow on Wednesday at 9 a.m. instead of having that appointment follow up within 7 days, because that's where we were seeing the issues.
I think you've come up with a really innovative way. You're being very proactive as opposed to the reactive of someone who may even be covering on the service overall, may not even know the patient and are behind the eight ball when the appointment isn't even scheduled. It does look like there's sort of a mix of responses of people typing in. Some are challenged by the fact that they have separate EMRs in both the outpatient and the hospital system. In some cases, they may be taking care of patients who are part of multiple different practices, and the challenges of then having to navigate, no pun intended, multiple different practices on multiple different EMRs overall. In some cases, they have no access to be able to do it from the hospital to the clinic. And in some cases, they do, but there may be payer-related contracting issues that may introduce a wrench into the plans of how to even ensure that people are getting regular follow-up within that timely fashion as well. So kudos to you in that regard. I'm going to poll, again, informally for the audience while we're asking you, Randy, how many of the sites that are on the call are using, whether it be modified LACE, LACE Plus, or a homegrown or alternative risk prediction tool to help better determine the readmission risk for their patients, either with an MI and or heart failure. It would be great to have people just type in. Randy, one of the things that we struggle with at our organization is that while it can color scheme people into a low green, intermediate or moderate yellow, and a high risk for readmission red, we have found that a lot of our patients all fall in the red category, and thus the cut points that were designed for a more general, heterogeneous mix of patients may do a good job, but when you're dealing with a heart failure and MI patients, most of them ended up being high risk. How did you deal with that overall, and was that your also observation when dealing with a more coned-down MI and heart failure population?
I would say that was pretty much the same that we got as well. Most of our heart failure patients are coming back at very high risk. Our Patient Navigator program, even though it was designed and created when we did the Patient Navigator program, we created that transitional care nurse. We have since extended that as well. We saw such a benefit from the patient, from the transitional care coordinator. We actually created 3 transitional care coordinator positions. Now there's one for our cancer floor, we have one for our typical med surg floor, and then our cardiac floor. And because our cardiac floor also, of course, sees typical med surg patients as well, also dialysis patients, and it's a bariatric center, we see all patients with a LACE score greater than 10. So just to cover that and help with those extra patients, so that way everybody was getting taken care of with that.
That's great, and it seems like there is, in general, most people are using some form. LACE tends to be a popular one, and depending upon your EMR vendor, leveraging what may have been built or part of what we would refer to as model build, a sort of out-of-the-box form. does make it easier to sort of implement overall. I think what you really reinforce is the success of being able to stratify and invest more resources in those people at highest need. I think one of our challenging issues that we found before the program that hopefully has been furthered in a good way by the program is we have limited resources, and all of us can probably, I won't poll people to ask if they have limited resources, but I can assure you that the answer is yes. And so the ability to consolidate the efforts to invest more time and energy and resources into those at highest risk for readmission pays dividends, conceivably financially, but definitely from a quality and patient satisfaction perspective overall. There's a question from Anne Marie. When you pull the list of the 10s, Randy, do you pull the patients to see and still see all patients, but you do something different with the 10s? Or are those transition care coordinators only seeing the 10s and the other individuals are a more standard what I'm going to call transition care coordinator workflow?
So that process has recently changed for us. We modified this as well. Before we were seeing patients who were only having a risk score greater than 10, unless they were CHF AMI. If anybody comes in with our process begins where when the patient comes in, my partner Julie will go through all readmissions every day and identify all the CHF AMI patients. We share a CHF and patient AMI list. So when I come in every day, the first thing I do is I open up my AMI and CHF list. If there's any new patients that came in, they're automatically put into that list. So it doesn't matter if their LACE is a 2. We're still going to do all the follow-up with them. But those patients that do have, prior to this change, we saw patients only with a LACE score greater than 10. Now what we do is I see every patient that comes on the floor, which is a 16-bed unit. Now if they're going to a SNF or they're being discharged to hospice, then of course I will not follow them. But if they're going home or to assisted living, I will. And then the process change that we just had is now that I see all the patients, and I'll follow the patients discharged from the ICU as well, we determine if their LACE score is less than 5, I may only do 2 follow-up calls with them. If their LACE score is between 6 and 10, I may only do 2 to 3. But if their LACE score is greater than 10, I call them once a week. And of course that depends on nursing judgment as well, which goes back to you were asking about process change. I think that's the biggest thing that we had is really a whole process change within the hospital and a culture shift, because now nurses, instead of just saying, hey Randy, this patient is a LACE score of 10, they're being admitted, their LACE is 10. If I have somebody who has a LACE score of 5 or 6, I may get a call from a nurse, or they'll stop me on the floor, say, hey, this patient's really sick, they're not quite getting the education. I know that you aren't following anybody with this LACE score, but could you follow them? So it really became a culture change within our system as well.
That's fantastic. And just in follow-up to Anne-Marie, that may be on the mind for a lot of people, besides your involvement and the follow-up calls, I guess 2 questions. A, if you're doing weekly calls, how long does that continue for? And the second question is, beyond you as a resource, is there more intensive or an added layer of education? Are pharmacists getting involved with doing dedicated teaching that they may not have otherwise done? In other words, are there other personnel who are also stratifying the intensity with which they connect with patients based on that LACE score as well?
So yeah, one of the things we're working on right now, matter of fact, because I just met with the pharmacy manager earlier this week, some of the pharmacists, now we have a dedicated pharmacist on the floor, and they're asking to start to see those CHF and AMI patients and do specific patient medication education with them. So they have that resource. We also, this last year, we opened up a heart failure clinic. So they are now being followed up by the heart failure clinic as well.
Great. kudos to you for all the amazing work that you're doing. I do want to encourage individuals in the midst of our next presentation, while questions come to mind, do not hesitate to type them in, and we'll try and get as many of them addressed as possible. Randy, thanks so much for your great work thus far to date and your continued great work, and we look forward to hearing more progress that you continue to make in those shared learnings. With that, I'm going to turn things over to Kim Marshall and let her introduce herself and the program that she has at University of Colorado.
Thank you, Ty, and nice presentation, Randy. So I'm Kim Marshall. I am the Clinical Quality Specialist at the University of Colorado Hospital. We're located in Aurora, Colorado, and you can see our nice view of our foothills that we have. We are an academic center, so we have over 673 beds. We are actually the closest hospital to our airport, Denver International Airport, so we actually receive quite a few out-of-state MI patients from the airport, so that in itself presents a challenge. But otherwise, we are a pretty big center. I just wanted to highlight an article, since most of us that participate in Focus MI participate in the Action Registry. And last September, there was a nice article that was written up about how we utilize the Action Registry for our quality improvement efforts. So from Aurora Healthcare, Jan mentioned that the value of the data really helps clarify for the abstractors how they are making sure that their definitions are on point. Then we also had Andrea Price from Indiana U. She brought up that the team, by using the registries, they help provide shared learning across the continuum of their care teams. And I was asked nicely to make a point, and we utilize the registry on a weekly basis to help make sure we're staying on track with our patients, and we'll talk a little bit about that later on how we present our data in our groups. I just wanted to point out, too, that even though we're a large academic center, we actually, I think, are kind of on the average size for the number of MIs that we report out every year to Action. We average about 300 a year. So I wanted, from my perspective, to point out, first, the challenges of process improvement. We all think that we just come up with this great plan and we'll just solve issues right away, and unfortunately, never does it occur as the top picture, but more the bottom. So we come up with the idea, and then we have to think about how we gather our teams. Then we have to create the brainstorming. What are we going to work on? I kind of put the big gully ship as our IT, but fortunately with the NCDR registry, we actually have data, because oftentimes the issues we have to deal with to get things going from an IT perspective is sometimes our biggest hurdles. And then, of course, implementing our plan, and then the challenges that come up with, it was a great idea on paper, but what's reality? So I just love this visual tool. I think it really highlights what most of us struggle with every day on working on trying to do process improvement. So kind of with a focus on our MI patients, back in 2014, we kind of just had a door-to-balloon team. Our big focus was on door-to-balloon times. We even felt we were doing okay, so we only needed to meet quarterly. It was kind of the ED team, our cath lab staff, and myself. So kind of a small group. And then we got asked to participate in the Patient Navigator Program, which was great because we continued to look at our door-to-balloon times, as well as recognizing the continuum of care that obviously goes beyond the cath lab. So we created a MI committee. And then we also decided in 2017 to join the ACC accreditation journey. And just this recently, a few weeks ago in May, we actually received our final accreditation. So that was a great thing for helping us continue to move forward. The one thing I did want to bring up kind of along our journey of our team for addressing our MI concerns for our patients, you know, it's not easy to gather that team. Like I said, our Door to Balloon team only met quarterly because some of the team members felt that certain issues that were brought up wasn't part of their domain. Of course, finding the right people to join your team that are engaged is always a challenge, and I think as those of us who facilitate, sometimes it's challenging. Are we the ones basically running the show, or do we actually have engagement and the team members participate? So that's always a challenge in itself. With the enactment of working on our accreditation, we created our AMI committee charter. And of course, it aligns us with our organizational goals to reduce AMI mortality and readmissions. And of course, our mission was just as a whole to improve the care that we provide our ACS patients. So our strategy, of course, was to pick what we were going to work on, and I think the Patient Navigator program really helped us focus in on the overall defect-free care. If you look back in 2014, we were at 64%. We did analyze through the NCDR tool, the drill downs, that cardiac rehab was our biggest focus. And you can see even a year later, again, before we joined the Patient Navigator program, we hadn't made much progress. So it was great strategy that we were able to get on board with the Patient Navigator program. It really helped our organization put a little more effort into this process improvement efforts. So again, you know, just to kind of keep us aligned with the organization. So again, the effort of hopefully improving our overall defect-free care was to align with the organization's goal, reducing readmissions and mortality. And again, then kind of the committee's goal, recognizing the fact that our cardiac rehab referral was going to be our first and biggest focus. So I, as the data manager or the quality improvement specialist, absolutely believe sharing is transformational. I think the more intimate that you are with the data and all the members of the team with the data, the more that you're going to be able to make those improvements that you're needed. One of the challenges, I think, when you become transparent in your sharing of data is you tend to want to defend what numbers are up there. And I think it's always humbling to know that there's different ways to look at data. Everyone looks at it slightly different ways. So instead of being defensive, I've always actually been appreciative of any feedback in the data that we share to make sure, one, that, again, my definitions are correctly interpreted, as well as sharing those definitions with the care team members. And then, of course, making sure that there was not an error in those abstraction issues. So we actually, with our AMI committee, developed this dashboard so that monthly when we meet, we can all see the areas of quality metrics that we've chosen to focus on. We actually even added the line of numerator-denominator because our physicians really want to understand how far off we are. And if you look, sometimes it's only 1 or 2 patients. Again, when you have a volume of under 300 a year that you're reporting out on, it doesn't take much to be less than the percentile of the national benchmarking. But it's good that we all see that, because a lot of times the caregivers think they're doing the right thing all the time and it's not their patients or it's not their issue. But again, we all need to be reminded that every patient, every time needs to be our focus. Again, just a little more transparency on our readmission rates. For AMI, we do try to make sure we review all the cases that come through. We actually could not find a reason why our Q2 17 blipped up so high, but it's a reality of the patient population, and we just kept striving to continue to improve upon that. So we did end up doing a great job of making our improvements of our overall defect-free care with our focus on our cardiac rehab referral population. So this is kind of over time. You can see we set a goal of greater than 75%, since that is what's required for recognition. And in fact, I hate to say, you can see in Q1 of 2017, we didn't quite make that 75%. So we did not get recognition from ACTION this year. We were really bummed about that because our team has done a great job overall making improvements, so that was a little disappointing for our team. But that's okay. We'll keep going forward. So one of the other challenges that I think of, you get often asked by those of us not intimately involved in our care teams of how do we present the efforts that we've put in, especially from administration. So this was one format that the Patient Navigator Program provided. So on the left-hand column, it's kind of like your baseline data. The middle column representing where you're currently at, and then the right-hand column demonstrating what our next steps or further efforts. And then again, the next slide kind of is demonstrating the same thing. Where were we at our baseline? Where are we currently at in our quality improvement efforts? Again, cardiac rehab referrals was our big focus. We had staff who attended daily rounds that were developed at the end of 2015 for cardiology. And with that, they worked closely with the staff to help create the order to make sure that the rehab referral is being placed. And then we also actually have the cardiac rehab staff kind of did a little restructuring of their department to make sure that they had a dedicated staff person to visit the patient while an inpatient. And then, of course, our future efforts are, restructuring cardiac rehab orientation, providing more evening classes. We also have fortunate to have a remodeling done, and I'll show a picture of that in a bit, of our cardiac rehab education center. And kind of my next couple slides are things we all know. We do know that accreditation is key. I kind of missed a little blip in my slide there, but that's okay. So we also have efforts moving forward, recognizing that bundle payments didn't become mandatory, but we're still continuing to help improve our efforts to reduce the cost of our patients with an MI. Oh, there we go. I did want to point out that it still is the #1 cause of death that most of us on the phone know, as well as the cost of taking care of these patients, which is why we all are involved in the Patient Navigator Program. And just as a reminder, I'm not really intimate with our finance department in my role, but it's easy always to see how we do on hospital compare with the cost of our AMI patients. So for our hospital, we were just underneath the national cost, and then that kind of just put us in the average there. The other area I wanted to highlight, so sometimes you're challenged with, well, why do we put the money and efforts into cardiac rehab? And this was a study done by Julian Holt-Lundstedt out of Brigham Young University, and she looked at over tens of thousands of middle-aged folks, and then 7 years later evaluated if they were still with us. And the biggest impact that she felt on keeping people alive from the middle-aged area was, of course, social integration. So keeping yourself not isolated from our peers. But one of the other areas that she even highlighted, what fifth on the list of keeping yourself alive, was to be involved in cardiac rehab. So for those of us unfortunate enough to have an MI, if you're one of those, cardiac rehab can help keep you alive in the future. And then the other thing I wanted to, again, highlight, this is a room that we were able to remodel, provide a nice education room for our cardiac rehab folks with a demonstration kitchen, and this was all based on the benefit of a very generous family contribution to help us further put efforts into our cardiac rehab team. So our cardiac rehab patients love this new room and are very, we are very privileged to have had that effort. And that's all I have for me today.
Kim, this is Ty. Thanks so much for a really thorough and great presentation. There are really a lot of things to touch on, and again, I want to remind individuals on the call to please type in questions that they have overall. There are several things to touch on, and I want to touch on one of them. I want to acknowledge first and foremost that you have always been very generous in terms of being transparent, both in terms of the processes that you implemented that were successful and unsuccessful, but where things didn't work as well as you would have otherwise liked. And I think that that's a healthy thing that we all take stock of overall. In terms of the data sharing and the process of transparency of data and moving clinicians, care team members, nurses, pharmacists, others in the right direction, you've done a great job of generating a monthly dashboard. I know we all feel like we're getting meetinged to death these days with lots of meetings, but how often, again, can you remind us that you're bringing together the larger team, including your physicians, to share data and try and figure out where you move the needle?
So we actually meet monthly for our MI patients. The physicians are invited every month. Of course, their attendance is not always possible monthly. I would say they end up showing up about quarterly, but we're fortunate enough to have a good representation from our advanced care providers at our monthly meeting, and they actually do a lot of the work directly with the patients. So I think it's good representation that we have of the direct care providers at our monthly meeting, and then the physicians attend when they're able. We also have a fellow who's been very involved with this group for the last year and for the next year, so that's always helpful too, to help share with our care teams the efforts. Currently, right now, as Ty presented at the NCDR meeting, our identification of MI patients is our current efforts that we're trying to make sure that they're coded appropriately. So that in itself is a challenge. So.
Oh, this is great. There are a bunch of questions that have been typed in the chat box related to cardiac rehab, and I'm going to read through a bunch of them, and I may have to just re-ping you with them. But, is there any weekend or holiday coverage at cardiac rehab? What are your hours? Who runs your cardiac rehab program? Is PT involved? If I've captured all of them, those are sort of who are the staff in terms of their makeup, what are your hours, and how do you handle off times?
So we are just Monday through Friday for cardiac rehab. I do know on Monday mornings they come in to try to capture who might have gotten missed or came in over the weekend, since obviously our AMI patients often only stay a day, at most two on average. The cardiac rehab team does try Friday afternoon to make sure that they have hit as many of the patients that they're aware of in the hospital, and then of course if anyone came in over the weekend and got missed on Monday, they will make phone calls to try to reach those patients. Hopefully, as far as getting the cardiac rehab referral order in, even though it is part of our order set, it sometimes does get missed, but hopefully that captures for the referral piece. Our cardiac rehab team is mainly made up of nurses and exercise physiologists, sorry about that. and they are all under the Department of the Cardiovascular Service line.
Perfect. And then one more quick one that just jumped in related to that is, do you have a sense of how many Phase 2 cardiac rehab patients run through the program on a daily basis?
I do not know how many run through. I do know that we've had to increase our number of sessions that we have to help accommodate. Being a large academic medical center, we're challenged with having patients access our cardiac rehab because it is actually embedded within the big organization. So anytime patients state we're a little too far, and of course the patients that come from out of state, our cardiac rehab folks do their best to try to set them up with cardiac rehab areas close to where the patient lives.
And I do think that's a key point that at least we've used in our own system, and it's easy for me to say this because I'm not the one who's directly doing it, but we've been very fortunate to have unbelievable cardiac rehab staff, as I think most are, who take the extra effort to find out that if the patient isn't geographically in proximity, or for that matter, flew into the airport in Denver and are going to be going back to Ohio or Virginia or San Francisco, wherever, they try and connect them and even send over the referral, is what we do, to their local cardiac rehab program to help with that transition process. Certainly patient-centered, but it's going one step further.
Yes.
Can I ask, going back to your dashboard for a second, I'll come back to cardiac rehab in a moment, but going back to your dashboard, we all know that many of the non-ST segment elevation myocardial infarctions and heart failure patients are ones that may be principally managed or co-managed by the hospice, and it's been great putting the numerator and denominator and finding out even small gaps can push you out of the desired range quickly, especially for topped-out measures. But can you speak a little bit to how you have been able to coordinate education, awareness, sharing of best practices with service lines beyond just the cardiologists themselves?
That's a great question. Fortunately, with efforts like accreditation, they are really good about challenging your organization about system-wide education, as well as sharing overall results to care teams not direct or infrequently involved. So I think our education piece often, of course, comes out with yearly competencies as for the big masses. And then, of course, anytime we have an opportunity to share outcomes with more folks, in fact, most recently our chief medical officer under the quality department is trying to get a grasp of all the efforts throughout the organization based on patient populations to try to share those. Then we also have a monthly meeting for quality and patient safety that the quality department has, and they invite different patient population areas to present out how processes are going and quality improvement efforts are going. So I think that's how we try to spread that word beyond just our intimate little care providers.
Perfect. And a question, Kim, and I'll follow this up with another one, is the time span usually between somebody being discharged post-MI and starting cardiac rehab for you on average runs about?
I'm going to say, because I honestly don't know exact numbers, just based on conversations in our meetings, it is up to about 2 to 3 weeks till they actually are able to get into rehab because of them being booked up. So that's why they're making efforts, one, to create orientation at a much sooner time and doing group orientations as opposed to individual orientation to help facilitate getting them into the classes sooner. As well as adding more classes so that we can try to get our patients in sooner as well.
Gotcha. And from an innovative perspective, beyond the geographic location, one of the challenges we face in our markets, and I would suspect many others do, is affordability for cardiac rehab if they have co-payments. And have you looked into any innovative web-based or app-based home-based cardiac rehab programs, recognizing it may not achieve all of the same goals of a dedicated Phase 2 program, but something is better than nothing. And I just didn't know your experience, or are you even talking about those types of possibilities going forward?
I personally don't have a good handle on that, not being in cardiac rehab, but I do know that, especially since some of our patients really come from pretty rural area that are often referred to us, that I know our cardiac rehab team does do a lot of talk with the walking exercise and those things if they can't make cardiac rehab, but beyond more details, I honestly don't know those.
Gotcha. Kim, you've been tremendous with this. We really appreciate your transparency about the learnings that you've had and areas where there's still opportunities to continue to do better. So thanks for presenting, and thanks to you and Randy for all the great work you guys did today and continue to do. We are lucky to learn from you on a regular basis. Kendra, if you were approaching towards the end, I wondered if you could just advance the next couple of slides for me.
Sure, absolutely.
And we'll go one more. This is just a reminder that the next webinar for this group is slotted for Thursday, November 29th, the week that follows Thanksgiving, if my memory serves me well, from 12 to 1 p.m. Eastern Standard Time. We will be sure to get you a reminder information well in advance of that, but if you want to put it on your calendars today, again, Thursday, November 29th. And if you could go to the next slide. Another reminder is that we do have a listserv for the Patient Navigator community. It's Patient Navigator Focus MI, all one word, at list.acc.org. It's an opportunity to be able to, A, join that group, to be able to listen about different comments that people have. And increasingly, we're encouraging people to post questions, share learnings, best ideas out there. This is really meant to be a virtual community where people can reach out to phone a friend, so to speak, except they're not picking up the phone, to be able to post questions, and certainly can do that in follow-up to today, but at any time as questions arise. A final thing before we just close today, many of you, including Randy and Kim, but many of you on the phone attend some of our national meetings that are dedicated towards quality improvement, performance improvement, and closing gaps in care. And one that's an obvious one is the NCDR meeting, which, if memory serves me correct, is slotted for this coming, meaning 2019, March 14th and 15th, or maybe the 13th through the 15th, in New Orleans. It usually precedes the ACC 2019 meeting, and it's never too early to start talking about opportunities to come up with projects that can be shared in a poster format. They're increasingly well attended. They're increasing in numbers year over year, and I would strongly encourage you, you may not think so, but I can all but assure you that something that you've done that's moved the needle at your own institution is likely to be well received by another person that's either on this phone today or that attends that meeting. And it's a great opportunity to be able to interact with peers, get back feedback about work that you're doing overall. So I'd encourage that. And one last thing is that in February of 2019, I believe dates yet to be determined, the American College of Cardiology puts on an annual cardiovascular summit, which is a combination of quality, improvement, operational excellence, finance, and leadership. It's really a potpourri of different topics. But the first time this past year, they opened up a poster session, and it will be continuing again this year. So there are really two opportunities to share your learnings and best practices, and opportunities where I think a lot of your peers can benefit. So with that, I'll have you advance the next slide, Kendra. And this is just a final thank you to all of you who participated in the program today. We'll give you back about 5 minutes. It looks like Valerie said March 13th through the 15th is the NCDR meeting. I believe those are the correct dates as well. It's a Wednesday through a Friday. We'll be sure to follow up if there's any correction to that, but would strongly encourage you, it's never too early to start thinking about posters to submit. Thanks again for all of your participation today. Thanks in particular to our two speakers, Randy and Kim, and hope you all have a great, have already had a great start to your summer and have a great summer to come. Thanks a lot, and Kendra, thanks for all your help.
Great. Thank you so much, Dr. Gluckman. And with that, we will conclude today's program. A very special thank you to our presenters and, of course, all of our participants for joining us today. Today's program is copyright 2018 by the American College of Cardiology with all rights reserved. This concludes today's program. Thank you. You may now disconnect.